Society board members, we're glad to see you here this afternoon. And I just want to make sure you realize if you need continuing education credits, you'll need to sign up. There's a list out front where you came in and checked in. So just to make sure you're all in the right place, this is the session on mental health in children and teens, tertiary prevention, the importance of early identification and intervention. So you've got the bios of both of our speakers. We're pleased to have Sue Abderholden. She has her MPH from the U in Public Health Administration from the School of Public Health. And she's been working, changing laws and attitudes that affect people with disabilities and their families. And over the last 14 years, she's been the executive director for NAMI, Minnesota, the National Alliance on Mental Illness. She's held positions with ARC of Minnesota, worked with Senator Paul Wellstone in the past, and the Pacer Center. And she's won numerous awards related to her work in public health. We also have Nancy Howe, who has over 9 years experience parenting a young adult with schizophrenia and advocating for mental health reform. She's been a guest speaker for Vail Place, on the advisory board for schizophrenic research studies at the U of M. She's presented many places, testified during our state legislative session in 2015. And in her role currently with NAMI, she's responsible for educating youth and families through classes and workshops. So welcome. The two of them will be speaking until about 2:15, and they will include some time for questions a little bit after 2.
Thank you so much. I always hate to be the speaker after lunch, so hopefully you'll be very awake during this time. So what we wanted to kind of talk about today is, one, to increase your understanding of prevention in mental health, which is something that we frankly rarely talk about, helping understand why early identification is important, and then increase your understanding of some of the tertiary prevention efforts in particular that are actually happening in Minnesota. So the World Health Organization, when they look at, so what is mental health, it is obviously very broad. And it's really where people are, living well in the community, they're utilizing their talents and gifts and contributing them to their community. They can cope with the everyday stressors of life. It's kind of all of those kinds of things. And mental health, of course, is a continuum from people having really excellent mental health to people having mental illnesses. Mental illnesses, and looking at a definition, it really affects your entire being. It affects your ability to think, your feelings, your mood, your ability to relate to others, and your daily functioning. It can make it difficult for a child to learn in the classroom. It can make it difficult for an adult to be productive in their job. It can create discord with family relationships, all of those kinds of things. It is an extremely treatable condition, which is very frustrating as a mental health advocate, because people often think that treatment is not effective, when in fact it is very effective. We don't know all the causes yet of mental illness. I think because of the wonderful brain research that is going on, we learn more and more all the time. We're kind of, it's kind of the last body of great research in terms of understanding parts of our body. We do know that that it's biological in nature, so we know when they do the MRI scans, you can see changes in the brain from someone who has schizophrenia, from someone who has bipolar disorder, and from someone who doesn't have a mental illness at all. We know that it affects both the structure and the chemistry of the brain. In terms of causes, certainly genetics plays a huge role. If you have someone in your family who's had schizophrenia, the chances that you or another family member will develop it are very high. The same would be true for depression and even bipolar disorder. We know that environment has a role to play, not just in the negative life experiences, exposure to trauma and things like that, but also things like pregnant women having the flu. All of those kinds of things can really affect the brain of an infant or a child, and all of that has a role to play. Mental illnesses are extremely common. Depending on which study you look at, it's 1 in 4, 1 in 5 adults, 1 in 10 for a serious mental illness, 1 in 5 children. One thing that we never ever talk about, though, is that this is a young person's illness. When we think about people with mental illnesses, we typically think about someone who's older. in their 50s, or their late 40s. We don't think about it in terms of children, but yet half of adults who experience a serious mental illness begin experiencing symptoms before the age of 14, and 75% by the age of 26. So if we only focus, for example, on the adult mental health system, we are waiting way too long. And unfortunately, that's generally what happens, is we just focus on adults who have the most serious and persistent mental illnesses, and we forget about all the impact that we can have on these children and teens and young adults. Just for reference, anxiety is the most common mental illness, followed by depression, and then, of course, bipolar disorder and schizophrenia.
Hi, everyone. Just to talk a little bit about the disabling effect on the global economy that mental illnesses have. Mental illnesses are the most disabling condition of individuals worldwide. Depression alone accounts for 4.3% of the global burden of disease and is among the largest single causes of disability worldwide, particularly for women. Mental illnesses are linked to other diseases such as cancer, cardiovascular disease, and HIV infections. Statistically, those with a severe and persistent mental illness will have a reduced life expectancy of approximately 52 years old. People with major depression and schizophrenia experience a 40 to 60% chance of premature death due to poor health and suicide. Suicide is the second most common cause of death among young people worldwide. The global cost of mental illnesses due to disability, loss of income, and medical costs is staggering. The cost is projected to rise to approximately $6 trillion by the year 2030.
Now, coming at this from a public health perspective, certainly it impacts the individual and their family, but it actually impacts our entire community, and that's something, again, that we don't often talk about. Children who have a mental illness have one of the highest suspension rates, which would make sense because symptoms are really come out as behaviors in children, and so the teacher might see those behaviors and then say, well, this isn't appropriate, and so now we're going to suspend that child. We also know that the more that a child is suspended, the higher, the greater risk of them dropping out of school. And again, young people who have a serious mental illness have one of the highest dropout rates, not just in Minnesota, but around the country. And what do we know when a young person drops out of high school? Usually they're not employable, or they end up in the juvenile justice system. And not just in Minnesota, but across the country, 70% of the children in the juvenile justice system have one or more mental health diagnoses. In terms of the higher unemployment, I also just want to mention that while work is an evidence-based practice, meaning you get better if you work, which of course makes sense. If you were to sit in your apartment all day, drinking coffee, smoking cigarettes, and watching daytime TV, there is absolutely no way that you're going to be able to get better. And so employment is a really important piece of this, and yet people with mental illnesses have the highest unemployment rate among all the disability groups. So it, again, leads someone to live in poverty and all of those kinds of things as well. Even looking at we know homelessness in general, we have a high percentage of people who have a mental illness. Even looking at homeless youth, again, a very, very high percentage of them also are living with a mental illness. And then, as Nancy mentioned before, suicide is a huge concern, and it's been rising in Minnesota greatly. So that is also a thing. So when we think about just our health in general in our community, we do need to be concerned because we know that when people are in these types of situations, that their overall health is going to be worse. And then you add a mental illness on top of it, and our outcomes are just poor, and we're paying for it. It's not like we're not paying for it. We are, but very inefficiently. We rarely in the mental health world talk about primary prevention. And I think part of it is we don't totally know how to prevent a mental illness from happening. We can certainly tell women to get the flu shots. We can certainly try to make sure that children are resilient. But we do know there are some protective factors that we need to look at generally in our society. We know that people who are living in poverty are under a much greater amount of stress and food insecurity, housing insecurity, and are frankly more likely to develop a mental illness. So when we think about things at the Capitol and people talk about MFIP, our state's welfare program, you know that amount has not been increased in, 30-some years. That is really a horrible thing that we are doing, frankly, to children and their parents, because they're now living in really abject poverty, and something we should be very concerned about. Certainly having clean water and air, very, very important in terms of just the impact even on, as we know from Flint, Michigan, the impact, that lead can have on a child can also lead to, ADHD and some other things like that. And then effective parental bonding. We know that an infant needs to bond with the mother in order to really have, a better life ahead of them and be healthy in every way possible. So when we try to advocate for at least primary prevention, we do need to think about health and wellness programs. So what can we do to make sure that people are, eating well, that they are getting exercise, that they, have a stable home? We need to look at early childhood programs. One of the huge factors is that if you're on MFIP, what they call MFIP child only, which means you've been determined disabled by the Social Security Administration, you are actually not eligible for child care. So if you're a mom who has a serious mental illness, when you're disabled by it, and you need to go to treatment, your choices, frankly, if you have no family to support you, is to leave your child in a dangerous situation or to skip treatment. And that's not good for any of us. So making sure that we have accessible early childhood programs will really help in the long term. Social and emotional learning. It's something that, unfortunately, we have legislators who are really scared of that word. But as we know, we have children who are being kicked out of daycare and kindergarten, first grade. Well, it's not that those are bad children. We know they're not bad. I mean, how many of you ever saw The Bad Seed? I mean, that just doesn't, I'm really aging myself now by that movie. But it isn't that children are born bad. And so those children just haven't learned to regulate their emotions and to know how to express their frustrations on things. And then parent education. We aren't born with that book in our head. And so really helping parents know how to really help their child grow and develop is also a really important piece of this.
Okay, so now we're going to talk a bit about secondary prevention. Youth who are at a higher risk of developing a mental health condition quite often have been exposed to one or more of these factors. Experiencing trauma in their home or community environments due to violence, physical abuse, or sexual abuse. They may have a genetic predisposition due to their family history. Being raised in a stressful environment where there isn't a strong family connection and support system or other adults they can talk to can greatly contribute to their emotional instability. Cultural impacts due to racism and historical trauma. If a mother is experiencing postpartum depression, it can affect her ability to bond with the child and create attachment problems, which can then create additional problems for the child down the road. If an older child or youth is living with a parent with a mental illness, this could put them in the position of having to go to work, to support the family, to care for other siblings, instead of going to school. Using drugs and alcohol, which can lead to substance abuse, can create and worsen anxiety and depression. The chronic stress of living in poverty, which can result in homelessness. Research has shown that not having access to stable housing profoundly affects mental and physical health, as Sue was saying earlier. And then we have the issue of bullying. Kids who are experiencing cyberbullying, which is a new and growing problem in colleges and universities, secondary education, or physical bullying in the school setting can lead to feelings of hopelessness and despair. So let's see. Sorry guys, just one second here.
Oh, the slide is still at the end.
Just one moment, I just have to click through to a different slide real quickly here. Okay, there we go, sorry about that. Okay, so the effects of childhood trauma have a profound effect on cognitive development, causing the following issues. Through relationships with caregivers, children learn to trust others, regulate their emotions, and interact with the world. When those relationships are unstable or unpredictable, children learn that they can't rely on others to help them, feel like they're a bad kid, and the world is a very threatening place to them. In terms of regulating their emotions, children who have experienced trauma have difficulty identifying, expressing, and managing their emotions. They often internalize or externalize stress reactions that can result in significant depression, anxiety, or anger. In terms of the immune system, normal biological function is partly determined by environment, so children with complex trauma may develop chronic or recurrent physical complaints, stomach aches, headaches, that sort of thing. Traumatized youth frequently suffer from body dysregulation, so they may be hypersensitive to sounds, smells, touch, or internal physical sensations. They may have trouble thinking clearly, reasoning and problem solving, and show deficits in language development at a very early age. This can also create a sense of hopelessness and just lack of self-worth. To be able to plan for a future with a sense of hope and purpose, a child needs to value themselves, which requires a sense of hope, a sense of control, and the ability to see their actions as having meaning and value. Children surrounded by violence in their homes and communities learn from a very early age that they can't trust, that the world isn't safe, and they feel powerless to change their circumstances, so they're more likely to engage in high-risk behaviors and engage in substance abuse. The long-term health consequences into adulthood. Childhood trauma has also been linked to increased medical conditions and can also result in higher rates of smoking, unprotected sex, and chronic illnesses such as heart disease, cancer, and early death. Okay, now I have to jump back to my previous slide here, so bear with me for just a sec. There we go. Okay, we're going to talk a little bit about some more secondary prevention. We're talking about screening again. Mental health screening in the school setting, often through a health class, which they're starting to do in local high schools, can allow teachers and parents to address behavioral issues early on, which can prevent problems from worsening at school or at home. With regard to training, it's important that teachers and others who work with youth are properly trained in the early warning signs of mental illness so it can be identified and treated as soon as possible. School-linked mental health programs connect or locate mental health resources with schools and students. These programs provide services that improve outcomes for children and youth with a mental health diagnosis by providing mental health professionals at each school. Did you want to say something more about that?
So I'm just going to add about School Linked. We have really a national recognized program in Minnesota, and it is not the school support personnel in the schools, school social workers, school psychologists, because they are often not clinicians. And so they have an important role to play in identifying and working with children. But once a child becomes identified as perhaps needing a diagnostic assessment or actual treatment, then we actually, through the state of Minnesota, funding goes to a mental health provider who then co-locates in the school. You have a firewall between the education records and the healthcare records. They can bill for insurance, and then the grant dollars actually pay for things for children who are uninsured or underinsured, and also for things that insurance doesn't pay for. What we have found through this program is that half of the children had never received treatment before, and half of those children had a serious mental illness. So we know that they weren't doing well in school, frankly. So it's been a really terrific program. We show great treatment plan completion rates, and actually children actually getting better and their symptoms going down. It is a well-loved program, I can tell you that, by not only the families and the kids, but also the teachers and the principals and the superintendents. They see school suspension rates go down, which of course is a good thing, and one program actually saw reading scores go up because clearly if you have the symptoms, that could be a barrier to learning as well. It's really brilliant, school-linked mental health. And we are now in about not quite half of the school districts. It's 60% of the school districts and about close to half of the school buildings in Minnesota. So we still have a little ways to go.
So part of the prevention is helping youth to understand how to do some self-care. That could take the form of meditation, or some mindfulness training. Teaching them how to do these practices definitely helps them learn how to reduce their own stress levels and anxiety, which is so prevalent, as Sue was saying earlier, and also helps them learn how to promote some emotional resiliency. So when they do come under high periods of stress, they know better how to manage their symptoms and move through those more difficult times emotionally. Identifying and addressing behavioral issues early in childhood that could be signs for a mental health condition is critical to the child's future success in school. Educating parents in coping skills through classes and workshops, which we hold through NAMI, and offering them emotional support through support groups really improves the outcomes for the children and youth with mental health problems. And again, mental illnesses can be intergenerational. The genetic link. In addition, parental mental health can also affect a child's educational attainment, future household income, and increase the probability of criminal convictions, which, of course, obviously really affect the children in the home. Several counties offer mother and baby programs now, which offer education support to young mothers who may not otherwise have the resources to help them parent their child in a healthy way.
I just want to mention before we go off secondary prevention, most people have heard of the ACEs project, so adverse childhood experiences. Unfortunately, in some ways, I think there's been too many little mini workshops that have gone out about ACEs, and so what we have is often we have someone who attended a workshop and might be a case manager for a county. They have that list of things can impact kids, and they start tracking the number that have happened to that child, and then look at the parent. The real purpose of the ACEs project, though, is to say we can't protect children from everything. There's going to be deaths, there's going to be tornadoes, there's going to be things that happen that we can't protect them from. And what we learned from the ACEs project is that some children are resilient and some are not. And so the whole point was to really try to figure out how can we make sure that all children are resilient, since, frankly, we can't protect them all. So tertiary prevention. This is really where we can have the greatest impact. And since we can't totally prevent a mental illness from occurring, certainly we can try to address kids who are at risk and, do some, general holistic public health in our community. We can prevent these illnesses from becoming disabling. But we have done a pretty awful job, not only in Minnesota, but across the country, in figuring out how to do that. A big thing is early identification. So what we know, even through our school-linked mental health grants, is that, we had kids who had a very serious mental illness sitting there in the classroom that weren't getting any help or treatment. We know on the adult side that people wait an average of 10 years before seeking treatment. And just think about all the things that can happen during those 10 years. Even a young person experiencing their first psychotic episode usually goes about 72 weeks before seeking treatment. You're hearing things that, that aren't really there. You're seeing things that aren't there, and yet you're still waiting 72 weeks. Now, we can certainly say that, stigma, has an impact there, but again, people are not seeking that treatment out. And we all know that the earlier you seek out and, identify and treat an illness, the better the outcomes are. We have not also done a good job about providing early intensive treatment. Typically, some of the evidence-based practices like assertive community treatment teams or ACT teams, the way that you get on them is that your illness has become so serious that you become disabled. You have been hospitalized numerous times or committed numerous times. Then we'll provide you the intensive services. And the way that we've explained it at the legislature, it's like going to your doctor tells you that you have cancer and says, come back when you hit stage 4. And that is exactly what we do in the mental health system. We wait and we don't provide any types of intensive services to a condition, especially schizophrenia, that we know later on can cost us millions of dollars, frankly, as a society in terms of rehospitalizations, but we don't do anything. That young person, once they finally get somewhere, typically it's because their psychosis has gotten so awful, they've been picked up by the police or maybe a crisis team and got to the emergency room. They might be hospitalized for a couple weeks. In the past, they would have gone to Anoka Metro Regional Treatment Center for a couple months, given some medication and come home. That would be it. That's not really what I would call a recovery model. And so what we really want to do under tertiary prevention is first try to really identify those kids early, make sure that we provide intensive treatment, not wait till they get too sick, and really keep the trajectory of their life going forward. We've had young people who've gone into a community support program where, we've got 40 and 50-year-olds there, and they look around and they say, please, dear God, tell me that's not my future. And what we want them to do is walk into a college classroom and see somebody else who has a mental illness. We want them to walk into a job and see somebody else who's living with a mental illness. We want their lives to go to the same road. We don't want them sitting there for the rest of their life living in the basement of their family home. We want them to be living with friends in the community like anyone else would in their 20s.
So right now, we're going to talk a little bit about what exactly is psychosis. How does it manifest in a person? First of all, just the most basic bullet points on psychosis. It's a very complicated condition, but first of all, confused thinking and communication. Confused thoughts are basically thoughts that the person is thinking that others can't understand, which could involve some delusional thinking. Delusional and thinking are false, fixed beliefs that are held by the person that are not shared by those around them and not rooted in reality. Hallucinations involve seeing, hearing, even smelling, feeling, or tasting things that aren't there. For people who have schizophrenia, hearing voices can be extremely troubling and debilitating. It's possible for a person to hear one or more voices inside and outside of their head. The messages are usually very negative and condemning. Because this is such a disabling symptom, there have been advances in developing special types of talk therapy that actually teach the person how to suppress and control the voices. In fact, this fall, the International Consortium on Hallucination Research will be sharing the latest research on findings and experience in the area of voices, hallucinations, and related experiences. So who gets psychosis? Oh, thank you. While many people think that psychosis is fairly rare, actually about 6 out of every 100 people will experience some symptom of psychosis in their lifetime. And that could be related to an illness, it could be related to a medication, it could be related to something going on with the brain itself. A whole host of things can cause these symptoms. It's found in all cultures, all levels of education, all economic statuses, social statuses. Men tend to develop their first episode of psychosis an average of 3 to 5 years younger than women do. First episode usually occurs in the teens and early 20s. What makes it so difficult is that when a first episode psychosis starts to emerging, quite often it's during a period of a young person's life when they're having their behavior is a little bit difficult to pin down anyway. They're going through the normal adolescent cycle. So some symptoms can actually mimic adolescent behavior. But the unfortunate thing is that untreated psychosis, as Sue was saying earlier, can really lead to a worsening of symptoms, risky behavior, drug and alcohol use, and legal problems. So it's really important to treat any symptoms of psychosis as soon as possible. What are the causes of psychosis? As I was saying earlier, it can be caused by different illnesses, medications, extreme stress can trigger symptoms, organic issues, brain tumors and cysts, drug, alcohol use and withdrawal, depression. So the first step is understanding what's happening after psychosis occurs, is checking for a general medical condition or drug use. So if a young person is hospitalized for an episode of psychosis, quite often the doctors may hold off a few weeks on making an actual diagnosis so that it gives them time to really look at what's going on with this young person, look at other symptoms, and make a more complete diagnosis.
So we actually have a program in Minnesota, and soon to be more of them, and around the country that really focus on what we call first episode programs. And I think it's the best really example of using tertiary prevention. This has been funded through the National Institute of Mental Health, but truly it's one of those things that you want to just go, well, of course this makes sense. How much more research do we need to do on this? And why aren't we doing this with other illnesses, including a young person experiencing their first manic episode, for example? So first what you try to do is to really bring young people in early. Part of the work is to really educate the community. It might be college campuses, the clinics there, pediatricians' offices. We actually have a rack card up in front that can be put out, so it's kind of, here's the signs and symptoms that you should be thinking about and worried about, and try to get someone in early. Oftentimes when someone might share with, a friend or, even a doctor saying, okay, this is going on, people tend to kind of back away from it and not necessarily take it seriously. What we want to do is to catch that young person when they're saying, isn't that odd? It's like the person in the TV is talking to me. We want to catch them at that point, and not when they're saying, there is someone in the TV talking to me. We want to catch them that early, because that's when we're going to have really the most success. Really looking at person-oriented treatment. So it's not just saying, we're just going to do this and you're going to, run through this kind of little program we have and then it's done. It's really looking at and talking with them about what are the side effects that you really can't live with? What are the goals that you have in your life? Because we want to help you achieve them. They start out with therapy. And we haven't always done therapy with people with schizophrenia. And yet, when you think about a young person in particular, they've just been told that perhaps they have schizophrenia. Do they have anything in their toolbox to be able to deal with that? Of course they don't. So they need therapy to really kind of deal with, in some ways, a loss, some grieving on their part as well, because this is happening to them and not necessarily to their friends. Family psychoeducation. Nobody got any information in their health class about how to deal with a loved one who has schizophrenia. We have no idea, right? And so, we're telling, parents are told all sorts of things, use tough love, which of course we wouldn't use on cancer. Why would we use it on schizophrenia? They use words like enabling. Well, do you enable a child with cancer by providing them a place to live and food and clothing and things like that? Of course not. We need to be treating this the same way. And families need help in figuring out what to do and what are appropriate steps to take. They also use cognitive remediation. We know that, the ability to process information is impacted with schizophrenia. So using computerized programs to really build up those skills. Social skills training. They might be very awkward in terms of dealing with people. We want to help them really be able to have friendships, know how to deal with others. Social skills is a really important place, has an important place in the workplace. So we need to help them do that so they're successful in work. Support groups. One of the worst things you can do is to have that young person think that they're the only one. They need the support of young people. They need to be in a group. They can see these other young people have it too. They can talk about it. They can feel better about it. They can support each other so that they're not traveling that journey alone. On medication, they're typically given a very low dose because they've gotten in early. We haven't waited till 72 weeks or longer, and now they're in the hospital and you're going to have to give them a higher dose. You start out on a much lower dose so they have much fewer side effects, which means they're more likely to actually take the medication. And then school and work. Nev Jones, who is a wonderful woman, she has her PhD, and she had a first psychotic episode. And what she talks about is, of all the things, the therapy was great, medication works, peer support, she said, but of all the things that helped for her was that she was able to get back and finish her PhD. And so getting someone back to school or work, again, so the trajectory of their life doesn't change much, is incredibly important. And one of the things that we have to start thinking about, too, is that instead of changing this young person to fit into a college, or a college campus and all the rules that go along with that, is how do we change those institutions to be more accepting of young people who are trying to come back? So now we're actually ready for questions. And I will just say on the first episode programs, the Congress actually did something on this. I know it's kind of amazing to hear that they did something, but they've actually set aside, initially it was 5%, and then last year it went up to 10% of the federal mental health block grant to go to first episode programs. We were also able to get money from the legislature last year, about $250,000, $260,000, to actually also go to programs in Minnesota. The RFPs were out a couple months ago. We heard that the Department of Human Services will decide in the next week week or two, we are hoping to get at least 3 programs started in Minnesota. Based on our population, we actually need 8 to be able to really meet the needs all over the state of Minnesota. And we know that especially in rural Minnesota, we're going to need to look at things like a Ronald McDonald House, and housing, so that people who are traveling long distances have a place to be as well. But again, I think this is one of the most exciting programs that we've done in terms of tertiary prevention. We can't prevent some of these young people from getting schizophrenia, but we can really make sure that we inhibit it from frankly, ruining their lives and becoming disabled. At this point, we're happy to take questions that people may have. We do have a booklet that we developed. Actually, NIMH really liked it, so it's up on their website as well, as a way to explain to young people and their family members about what this is and what kinds of things they can really advocate for, just in case they don't have a program near them, but they can still advocate for those services. Oh, okay. Are there questions?
This isn't quite fully formulated yet, but we've been talking a lot about mental health. What is the role with teens and substance abuse in mental health? And I know particularly with your school-based, you talked about the school-based mental health, which I think is fantastic, but Minnesota doesn't really have a lot of prevention in schools when in terms of substance abuse or even addressing it. So what do you think? Do you think that's kind of coming down the pike, so to speak, or do you think it's still kind of out in nowhere land?
Well, actually, we have a lot of chemical dependency counselors in the schools. That is certainly it. What we have not done, and we've just really gotten started on the adult side, is truly integrated dual diagnosis treatment. And we've understood the importance in adults, but we really have not looked at it in terms of kids and what kinds of things can be done there. Because sometimes, as we know, that young people might self-medicate because they're hearing the voices or because they're sad or whatever might be going on. And so it's hard to kind of pull them out separately. And unfortunately, our systems are very separate and have not really worked together. The other thing that is also hopefully happening is they're called Certified Community Behavioral Health Centers. This is a federal pilot project. Minnesota got a planning grant. We're hoping to be one of the 8 of the 24 states that have a planning grant that will get this. And in some ways, it goes back to how President Kennedy actually envisioned community mental health centers, where they provide everything, including connection to dual diagnosis treatment, crisis services, the whole thing. And so I think the more that we bring the 2 groups together and really work better, that will help those young people as well.
Thank you for that. So I work primarily with undergraduate students here at the university and have noticed quite an increase in interest in mental health, even in the last year and a half. And I'm wondering if you have any recommendations or thoughts. A lot of what you said I could see fitting, but I think a lot, as like the older young adults, I'm wondering if you just have thoughts on how to be most supportive of our students who are struggling with mental health, as well on an individual basis, I guess, but as well as like how could we help encourage student groups to address a lot of these things, or I guess other resources.
Great question. So I know that on the University of Minnesota campus, there is an Active Minds group. There's actually soon to be a NAMI on campus group. So there are people really working at raising awareness. And there is a lot more awareness than there was before. When people even look at our mental health system, I never say that our mental health system is broken, because we never had one. What we are really doing is building a mental health system, and that is a totally different thing. And the awareness is absolutely up. We're not treating the same number of people that we did back in 2001. We are treating more people because more people are coming forward. And I think particularly among teens and young adults, there is greater awareness, and they're a little bit more willing to talk about it. Doesn't mean they're more willing to seek treatment. And I think what they have to learn, and whether it's doing basic, suicide prevention, having, materials around campus about here's what you need to worry about. The website is great because it has a list of great resources for young people to know what to do. But I think it's kind of the next step. They're willing to talk about it, which is good, but how do we do the next step? So if you're worried, how do you help your friend? If you're worried about yourself, where do you go to seek treatment? And I think it's really tough. I was at a conference yesterday with counties, and they were really talking about how, how do you even enter the mental health system? And I get pretty frustrated because I know that a lot of our large healthcare systems have seen, especially since the Affordable Care Act, more people using the emergency room, generally speaking. And so what have they done? They've developed urgent care. None of those urgent cares have a mental health professional. And why wouldn't we? You know, I mean, that would make it very easy for all of us to know what to do, because you don't just go to an emergency room because you think you need to be hospitalized. People go to an emergency room because they don't know where else to go, or because the clinic is closed, you know, all sorts of reasons like that. So, so we also need to make sure that young people on campus know where to go if, you know, if Boynton's closed.
Thank you for your presentation. So you've maybe sort of started to address the question I was going to ask. I guess I was really surprised that someone having a first episode would wait over a year before seeking care. So what role do you see of like primary or like family physicians having? Because I think about, like, if I've gone for a physical, I've never been asked about my mental health and how I feel. Is there a role for them, or are people that are having these episodes probably not going to their doctor for a physical anyway?
Most likely they're not going to their doctor. And I do think that, especially surrounding schizophrenia, that there's a lot more stigma than, for example, depression or ADHD. And in some ways, it's really related to the discussion that you had beforehand about violence and mental illness, and that unfortunately people are really linking them. And so the more that we link them, the more scary it is to come forward. We've had young people who have had, you know, were working, you know, started developing symptoms, and their employer wouldn't let them back until the mental health professional said, yes, I will assure you that they won't shoot someone. You know, I mean, who does that for any other illness? And so if you think that everyone's going to think you're violent, are you really going to come forward and say that that's what you have? You're not. And so I think we really need to start unlinking those two things because they aren't linked. It's a very small percentage of people with a serious mental illness who commit a violent act with a gun. And so we need to really, we need to talk about that differently and make it okay, frankly, for young people to come forward.
I was just curious because we are, recent statistics that just came out showed that our expenditures, our health expenditures for mental health now are the highest of all expenses for healthcare, superseding even cardiac and thoracic and things like that. After all these years of early intervention and identification, and the number of children now who are taking antidepressants is about 1 in 10, should we be expecting a change in the rapid increase in suicides amongst, for example, girls who are between 10 and 14 years in Minnesota were dying at a higher rate last year than anybody except 45-year-old men? Shouldn't we be seeing something with all this treatment and identification?
Yes and no. So what we do know is with adults that they've actually seen a family practitioner within the last 6 months. So we know that they actually had some interaction. But that's why we need to make sure that schools are actually aware. We were the first state in the country to pass a law requiring teachers to have continuing education on early warning signs of mental illness. But just this session, we passed a law saying they had to have 1 hour of suicide prevention training. We do a program in the school called Ending the Silence that teaches young people about what the symptoms are and what to do if they're worried about themselves or another person. And what we found is that when we left, and those young people would go to talk to a teacher, they would be like, oh no, it's, don't worry about it. And so we wanted to make sure that teachers actually knew what those suicide warnings were. Because the mental health professionals are there to actually treat a child once they've been identified. And what we want to make sure is that we're better, and teachers are better at identifying some of those things in kids. I would love to see the study that say we spend more on mental health than other things because I know private insurance doesn't pay for everything. They don't follow mental health parity. Medicaid has a huge discriminatory policy against treatment for mental illness, as does Medicare. So I'd be interested in what they actually counted in those dollars. Whether it's, any state institution does not get Medicaid funds. All of that is state and local dollars in any state in the country because you can't pay for anything over 16 beds. So I'd be really interested in looking at this study to see what costs they included, frankly. I just know how hard it is for families to access the treatment, and they end up with huge bills because their insurance doesn't cover things.
Thank you very, very much. I'm wondering, I've got a couple questions. I am a reading tutor in a couple of elementary schools in South Minneapolis, and wondering if you are seeing an increase in the number of younger children with mental health issues. And of course, some of that I see, you mentioned chronic stress, such as poverty. And frankly, I really see that too. So I'm wondering if you see an increase in that, and then also the at-risk racism and how other cultures, parents as well, all cultures, deal with having a child, a young child, with mental illness. Thank you.
So we don't have any studies saying that the prevalence rate is greater, but what we do hear from teachers, from schools, frankly, all across the state, is that they're seeing children younger and younger who really are not self-regulated. You have a lot of problems even in Head Start. We see child care organizations, kicking kids out because of their behaviors. And a lot of those kids really have had numerous adverse childhood experiences and are not able to work that through. So I do think really creating early childhood mental health is really important. And it's not about medication. It really is about, how to help this child learn some of these skills, how to help the parent work with that child as well. I think that's really important. So I'm on Twitter with advocacy groups all over the world. And I can tell you that nobody's doing a great job. We have actually in the United Kingdom, things are blowing up there right now in their children's mental health system. I see tweets out of Australia, people complaining about lack of access. So it's not like, and even in this country, it's not like I would look to a state and say, well, that's where I would go. Because in fact, Minnesota is actually viewed as one of the better states for providing mental health services. We've actually increased the dollars over each of the years over the last 4 years. There was one, I always like to educate people on the study. There's a study put out by the Treatment Advocacy Center saying that Minnesota has the lowest number of beds per population. CARE 11 just quoted it again last week. It really is a study that doesn't make any sense because the only thing they count are state-operated beds. And so in Minnesota, we have a lot of community hospital beds, and we have our community behavioral health hospitals. So we have all these other beds, thousands of beds, but they didn't count them in the study. And they were using that to say which state does the best. And I just want to tell you that the #1 state in that study was Mississippi. And I can assure you that none of us want to move to Mississippi for their mental health care. We don't judge any healthcare system by the number of beds they have. We look at all sorts of other types of outcomes, easy access, are we getting people early, are they going back to work, all of those kinds of things as well. I mean, are we finished building our mental health system in Minnesota? Absolutely not. Is there more that we need to do? Absolutely. But I do feel like we have a foundation, especially for community services that other states frankly don't have, but we still have a long way to go. And it's time.
I think, we're going to take one more question maybe. Is that okay?
Actually, my question is in regard to that study itself. Do you think that possibly that study could be referencing the more like acute kind of mental health things? Like in an ER, usually they'll have a specific area for it, but those areas get filled, or they're almost always full, to the point that they'll start leaking to other areas of ERs, and then you have a massive drain on the ER system itself. Or especially when it comes to pediatric or the children's mental illness, where there are very few hospitals around that actually can, or ERs anyway, that can actually deal with that, and the ones that can are always full. And what do you see in the future for the development of that, at least in an acute setting?
This was actually what I just presented on yesterday. When we think about our crisis system, we have to think larger. We have to think about warm lines, crisis lines, mobile crisis teams, crisis residential, mental health professionals in regular urgent care, ER physicians who are willing to own those patients that come in, because many of them say they're not our patients. Yes, they are, and you need to treat them. Separate psychiatric emergency rooms, because the noise and the lights can be really hard for someone who's in psychosis. psychosis, making sure we have crisis residential, making sure we have good transition plans, making sure that we have follow-up in the community. All of those things, you know, in regular healthcare, we have a lot of people that end up in the emergency room who need help, but they don't necessarily need to be hospitalized. So what do we do when that person doesn't need to be hospitalized? And we need to make sure we have those community services as well. I mean, one thing I'll just point out is that at Anoka Regional Treatment Center right now, about 55% of the people there don't need to be there. They're waiting for community services. So just think about if we were able to actually build those supportive housing arrangements, be able to move people out, we'd be able to move people through the system. We have, in some ways, while I don't deny, especially on the kids side, we probably do need some more hospital beds, but we also have a flow issue. How do we prevent and identify and help people early? How do we make sure they get to the right system at the right time? And when they don't need that level of care anymore, making sure that they can move back into the community. So, so when people say, well, we just need more beds, we won't solve the problem. People spend probably less than 1% of their lives in a hospital bed. So if that's the only thing we focus on, we'll have totally missed the boat.
Thank you both for giving that. Thank you for coming. I think we can give them a good round of applause.
And there's resources up here.
Yes. And there's quite a stack of materials up here, so we encourage you to come and check this out and grab them. The next session starts at 2:30. The programmatic approaches to gun violence panel is up here, and then the session on the water quality is up on the 3rd floor in the Mississippi room.